Unit 1.4 Diagnostic Tests and Hypothesis Corroboration. The objectives of the class are: distinguish the types of diagnostic tests based on frequent clinical cases in medical practice. Explain the clinical utility of diagnostic tests considering sensitivity, specificity, and their impact on medical decision-making. Relate the choice of diagnostic tests to the sequence of clinical reasoning from the initial hypothesis to confirmation or ruling out. Analyze situations of overuse of diagnostic tests, identifying risks, costs, and consequences in patient care. In this class, we will talk about diagnostic tests and their role in corroborating clinical hypotheses. We will review their importance, the different types, and how to use them rationally to improve patient care. Diagnostic tests do not replace the medical history or physical examination. They complement them. They allow us to confirm or rule out hypotheses, guide treatment, and estimate prognosis. They always follow a sequential process, starting with initial tests, continuing with confirmatory ones, and in some cases including follow-up or prognostic tests. A fundamental concept is sensitivity and specificity. Sensitivity measures a test's ability to detect patients who truly have the disease. Specificity, on the other hand, indicates how good a test is at identifying healthy individuals. In practice, we use sensitive tests for screening because if they are negative, they rule out disease, and specific tests for confirmation because a positive result is almost always definitive. We can classify diagnostic tests into four main groups: initial or screening tests, confirmatory tests, follow-up tests, and prognostic tests. Let's review each of them. Initial tests are used to detect disease early or rule it out in at-risk patients. They are highly sensitive, less invasive, and lower cost. Examples include glycated hemoglobin for diabetes, mammography, or rapid antigen tests. Their frequency depends on the disease and guidelines. For example, mammography every 1 to 2 years, cervical cytology every 3 to 5 years, colonoscopy every 10 years in average-risk adults. Confirmatory tests are requested after a positive initial test or when clinical suspicion is strong. They are highly specific and considered the gold standard. They are usually more expensive and invasive. Common examples include biopsy to confirm cancer, colonoscopy, or gas chromatography in toxicology. Follow-up tests help monitor treatment response or disease progression, such as viral load in HIV patients. Prognostic tests, on the other hand, allow us to estimate the evolution and risk of complications, such as the Glasgow scale in trauma or troponins in acute coronary syndrome. Overuse of tests, also called overtesting, occurs when unnecessary studies are requested. This may cause radiation exposure, anxiety, complications, and high costs. Causes include fear of being wrong, patient expectations, and lack of clear criteria. To avoid it, we must rely on clinical guidelines and reasoning. Sometimes, when performing a diagnostic test for a specific hypothesis, unexpected findings appear, called incidentalomas. They are very common in CT or MRI scans. A typical example is discovering a liver nodule on an abdominal CT ordered for abdominal pain. The problem with incidentalomas is that they can lead to overdiagnosis and overtreatment. This means more tests, more biopsies, more anxiety for the patient, and overload for the healthcare system, without necessarily changing the prognosis. To decide what to do with an incidental finding, it is necessary to assess whether it is clinically relevant. Guidelines such as those of the American College of Radiology help in decision-making. We must also consider age, comorbidities, and risks of further studies. Most importantly, explain clearly to the patient what the finding means. In many cases, the best option is simply surveillance. In conclusion, the value of diagnostic tests is not in ordering many, but in ordering the right ones, interpreting them in context, and using them to make better decisions for our patients, always with an ethical approach and clear communication.